Welcome to the Gyne Awareness Podcast, real talk to understanding gynecologic conditions and care. The goal of this podcast is to bring you clear, evidence-based medical information by experts in the field of gynecology to help empower you in your health journey. Participants on this podcast are healthcare professionals, specialists and advocates in the field of minimally invasive gynecologic surgery. The views and opinions shared in this podcast are those of the speakers and do not necessarily reflect the official policy of AAGL. This content is provided for general educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Listeners should always seek the guidance of a qualified healthcare provider with any questions about their own health. If you are experiencing a medical emergency, call 911 or your local emergency number immediately.
Hello there. My name is Dr. Angela Chaudhari, and I'm a gynecologic surgeon and professor at Northwestern Medicine. I am your host today for the AAGL Gyne Awareness Podcast, a podcast designed for our patients to empower them in their health journeys. We are bringing you experts in the field to hear the real truth about conditions that impact so many people. Our focus today is on the current and future landscape of the medical management of endometriosis. So let's dive right in and meet our panelists. First, Dr. Shanti Mohling is a minimally invasive gynecologic surgeon at Northwest Endometriosis and Pelvic Surgery in Portland, Oregon, with a clinical focus on pelvic pain. Next, Dr. Sony Singh is a professor and chairman in the Department of Obstetrics and Gynecology at the University of Ottawa and research chair in gynecologic surgery in Ottawa, Canada. And last but certainly not least is Dr. Cara, the section head of minimally invasive gynecologic surgery and medical gynecology, as well as the director of innovation at the Cleveland Clinic in Cleveland, Ohio. Yay, I'm so excited you guys are all here with us today. I'm so excited to talk about this particular topic today because we are talking about the medical management of endometriosis. And it might seem weird to some of our listeners because we are all consultant endometriosis surgeons. We have all these patients that come to us every day looking for endometriosis surgery. But I think we all recognize that there is certainly a very important role for medical management in the treatment of endometriosis. So I'd really like to hear your guys' thoughts as we think about our endometriosis patients that come in. When you first have a patient who comes in and you really want to talk to them first line, you think they have a new diagnosis of endometriosis, what's your go-to for managing that endometriosis to start? Do we think about birth control pills, progesterones, IUDs? Sony, why don't you take this one away?
Yeah, no, thank you so much for the question. And so glad to be here as well. When we first see a patient, it really is very important to take a full history and to evaluate, as we've talked about before, what are the main goals for that patient. And I think when we come down to common goals, then we can figure out how we want to manage the problem. And so for some people, it may be that they want to conceive, in which case medical management doesn't have a great role other than pain relief, perhaps with anti-inflammatories or acetaminophen and other things. But when it comes to managing disease as they prepare for surgery or long-term management, then we look at hormonal options as well. None of them really modify the disease. That's important to remember. There is some evidence that progestins that aren't necessarily available in the US, that are available elsewhere, might actually change some of the disease, such as shrinking endometriomas or shrinking deep disease. But in general, these are medications to manage symptoms. And I think that's important to remember. With the exception of if you ever manage an ovarian endometrioma, long-term medical management can help prevent recurrence. That's one of the key concepts that we do try to share. So back to summary goals, deciding what you want to work on together, focusing on those goals, and then introducing those options.
You know, it's funny because there are so many different medications that people talk about, right? Like when oftentimes patients come to us and they say, I've been on ortho-tricycline, let's say, I'm going to just throw out any birth control, a tricyclic, triphasic, or oral contraceptive. And they say, like, I've been on this drug now for 5 years and everyone says it should work, but it doesn't work. What do you really tell them? You know, like, what's the next step for them maybe?
I think you're exactly right. And by the time patients get to us, they've seen many other physicians. They've probably tried many other medications, and they're probably hesitant to hear even the words of medical therapy again. So I think first and foremost, I validate their hesitancy, right? I always value their experience and understand where they're coming from when the last thing they probably want to hear is medications. But what I try to stress is that even though they may have tried medications before, there's a whole wide range of medications out there that could potentially be newer that they haven't tried yet. I also always let them know that this is part of a master treatment plan. So it's not that we're saying medications are what we're offering solely and that this is going to fix their disease or take it away. That is not my message. My message is truly to educate my patients that this is just one part of the entire picture that the tribe that we're building around them. And so ultimately, it's the patient's decision, and it really depends on, again, their priorities. Is their priorities pain? Is it pregnancy? Because if they desire pregnancy, then medications are obviously not on the table. But I think number one is validating their hesitancy and then educating them on the current options that are available.
Yeah. And what type of options do you offer them?
Yes, great question. So, I wish, I'm looking at like the newer medications, right? Like the newer GnRH antagonists. And I think all of us are waiting for that medication that's non-hormonal, right? And we'll talk about that at the end of like what's on the forefront and what are we really desiring. But I will say that the newer medications that are on the line are going to be the GnRH antagonists. We've had the GnRH agonists for a while. The antagonists are the newer kids on the block. With that being said, I think they typically should not be first line, typically in my patient population. So I typically recommend combined hormonal suppression or progestin only to start with a wide range within that. And then if those things are not working, then I will bring up the option of a GnRH agonist or antagonist. I think antagonists have the benefit and that you can dose them differently, and you can also reverse them more quickly. So with the GnRH agonists like the Lupron, right, that's 1 month or 3 months at a time. It's very hard to reverse. The side effects are quite high. I do think the antagonists offer a benefit in that you can dose them slowly, you can taper them off. And so I think sometimes they can be a little bit better tolerated. With that being said, again, my message is that is part of a global picture of pelvic floor physical therapy potentially, right? Central acting medications. Is surgery part of the picture as well? That's just one part of the master picture.
It's so interesting because I think so many of our patients come to us and they've only been offered birth control, right? And so I tell them there are so many different types of birth control. There's progesterone-only medications. We can even try IUDs, though I would say that some of our researchers will tell us they're not supposed to work. I think in real life, we do sometimes finding them to work. And then, of course, these newer drugs when these first-line therapies don't come out. But, as Sony alluded to when we first started talking, there are a lot of patients who like these types of medications that impact their hormones create a lot of side effects. I know, Shanti, you shared with us that you have a lot of patients that come to you that have been on medications for a long time. What are the barriers to taking some of these medical therapies that you've seen in your practice?
So that's an interesting question. And I would say that, of course, one of the barriers is going to be that they're expensive and if their insurance doesn't cover it. I would say also that most of the patients who come to me really don't want to be on a GnRH analog. And so that brings me to really what one of the biggest barriers I see is there's a lot of misinformation on social media. And so when you're thinking about all the ways that we might offer treatment to someone, sometimes maybe a temporary treatment with a GnRH analog is going to buy them time, till after their wedding when they're going to have surgery or whatever their current circumstance is that maybe they're 51 years old. They don't want to have surgery. They want a little bit of time. Then that might be a place, but many of them will be fully resistant because of what they've seen online, some of which may be valuable and true, and some of it may not be so valuable, and maybe someone's personal experience that had nothing to do with the drug itself, there is some value to social media, but sometimes it may dissuade patients from looking at all their options with clarity.
Yeah.
Yeah.
I hear you exactly what you're saying, Shanti, because really it's like so many of my patients, I'll say like this could be a really good long-term therapy for you if you don't have side effects, right? This could be a bridge to get you, like, as you mentioned, past your wedding, right? Like past your next big vacation, past your kid's graduation, whatever it is that you have coming up in your life. Or this could be something that really bridges you into menopause, depending on your age. And I think this goes back to sort of what Sony was talking about in terms of looking to really figure out what their goals of therapy are. And there are so many patients who benefit from surgery. We obviously know that as surgeons, but there are a lot of patients who are really looking for like that non-surgical option too. You know, one of the things that I find that can be really difficult for me is my patients think about hormones, right? We think about all the different cancers we can see with hormones these days. There is so much both good information and misinformation on the internet, as you mentioned, Shanti, right? Like, how do you guys counsel patients about sort of either long-term hormonal therapies or long-term anti-hormonal therapies with some of our GRNH antagonists? Sony, what do you see with your patients in Canada?
Yeah, so I think first and foremost, I want to acknowledge that the folks online today are surgical experts who focus on a lot of patients who failed other therapies. I try to put myself back in the shoes of my colleagues, family medicine, primary gynecology. What would you offer someone who comes in? So that comes back to the counseling that you're referring to. You know, there are advantages to oral contraceptives. The main one is a contraceptive. So when I think about my own family, my daughter, and extended family, what would you want them when they come in and they say, you know what? I want to be able to have an effective contraception, plus I've got pain I want to manage with. We know that oral contraceptives have changed the way in which we manage women's health. And so there is a reduction in ovarian cancer risk. There's a reduction in endometrial cancer risk, anemia and blood loss decrease. So I talk a lot about the advantages and why you may want to consider that. And at the same time, we have to talk about the contraindications. And we won't go over all of them, but you want to make sure that somebody's not got a history of blood clots, that if they're a smoker over the age of 35 or have a history of other cancers that you shouldn't use it on. So I go through all of those things with the patient, just as all of you do. But I want to always make sure I have that same discussion with everyone because I don't know what they've read on social media or where they've come from. In terms of long-term impact, I think that the longer that people use these therapies, and that's why I like to start with oral contraceptives or progestins alone, they're safe. Overall, that's what my message would be. When we get into the GnRH antagonist or agonist, and if you don't give what we call add back, then I worry about bone and bone health. And so, but that's a individual discussion and counseling that you need to follow. So as gynecologists, we need to know about these issues and we need to talk about them with patients. But as Shanti said, sometimes it may be short term to stop that bleeding so that you can make it to your surgery and your blood count can get better, or give you the symptom relief you need. But then I'm going to talk to you about what the long-term implications are, because I do see that endometriosis is a chronic condition and that it isn't something we can simply cure, that we do need to support people with the adjunct of medical therapy often.
Really well said, Sony. I mean, I really think when we think about some of these different drugs, I do think they carry a lot of stigma with them oftentimes. But then we have a whole nother group of patients that maybe never make it to our offices, right? As surgeons who are looking just for this medical therapy. So I think that's why it's so important for us to really know all sides of this to ensure that they really have had that full counseling before they got to our office. And, you know, I have patients who come to me and said, my doctor said I had to come to you because I think I have this, but I'm definitely not having surgery. Great. Like, let's talk about all these different ways that we can still continue to treat you to get you in with, you know, the right people to control your pelvic pain, you know, outside of surgery with physical therapy or PM&R, right? And so I think all of those things sort of play into our counseling and what we really need. Okay, I'm going to open this up to the whole group. Like, I really want to know what you guys think. Where do you think our biggest unmet needs in medical management currently are in our practice for treatment of endometriosis? Fire away.
I have one comment, and then I'm going to fire that away. Okay, Angela, one thing I just want to bring up really quick, I know we're focusing on endo, but I still want to forget to bring it up, is that many patients have concurrent adenomyosis. And so I think this is also another reason why we should be including medications as part of our toolbox, because if someone has adenomyosis in addition to endometriosis, and they're still having pain after an excision surgery. They want to keep their uterus for personal reasons. Sometimes the way we can control the adeno is with hormonal suppression. So I just want to bring that up too, that sometimes we're tackling multiple different pathophysiologic processes that we have to keep in mind.
I like to say,
I love that. See, we're all like excited. I want to add, we kind of have underplayed the role of a levonorgestrel IUD today.
Yes.
And to Cara's point, adenomyosis, what we see that maybe at least in 30% of our patients with endo, if not more. And that if they're still having primary dysmenorrhea, really like central pain after excision of endometriosis, an IUD may be a great solution for someone who particularly doesn't want to do an oral medication and wants to keep their uterus and doesn't quite yet want to get pregnancy, but they want to have that, they want to keep their uterus. So yeah, I just want to make a plug that very often I will offer that being placed at the time of surgery, as I'm sure Sony and Cara and you, Angela, also do. That, to painlessly have it placed while you're asleep is a great thought. And if you don't like it, it's easy to take out.
So
100%.
just because Cara started this whole thing, I want to just go on to that. So the patients with endometriosis, especially deep disease, even as severe as it is, I have something I'm treating. We know they have adenomyosis, I'm treating. The patients who don't have endometriosis, who still suffer with pelvic pain, or have what we call superficial or peritoneal disease, that may not be the pain source. But the period can be a significant pain generator that results in major pain in their whole body and inflicts this whole chronic pain symptomatology. So I think one of the things is, as surgeons, we focus so much on the pathology, but as chronic pain experts as well, because you have to understand chronic pain and endo together, that somehow helping stop that pain generation. And one way is to perhaps stop the period or reduce the volume or the pain around the period actually helps the entire body feel safer. And you can then use the physical medicine rehab, which, Angela, to hear you say that is music to my ears, to get into the physio, to get the other support. So it's not just about knowing that you have a pathology, because even when it's negative, we still have opportunities to help you control the symptoms and ultimately.
Yeah, I really love that. Medical management along with multidisciplinary care is like what I tout to all my patients. So I am definitely on board. And you guys, this is clearly a sign we need to bring everybody back for an adenomyosis podcast, because I have a lot of thoughts about it as well. I call it endometriosis' ugly stepsister that nobody actually talks about, right? And so it's really, really such an important piece that I think our patients will be excited to learn about. Okay. So let's talk about, guys, what's on the horizon? What's coming out? What are you guys seeing in research? What do you think we really need to be better treating our patients with endometriosis medically?
All right, Gwen was firing me up. Fire in my belly. Are you ready? Okay, hang on. It is this entire new area of AI, precision medicine, and patient-centered data that's going to tailor individualized care. So my brain is blowing up in the space of how can we diagnose this sooner? How can we tailor management? How can we dose patients differently? How do we know who's going to benefit quicker from surgery versus alternate mechanisms? I think this, blanket that we do oftentimes of just trialing different medications. I mean, a beauty that we have is that we have so many different types of hormonal suppression, a lot, right? But that also means sometimes you have to try a lot until we know exactly what works, right? I oftentimes tell my patients, I'm almost like a janitor with a bunch of keys. I'm going to keep trying the key in that door until it unlocks and we find something that works. And I think a really incredibly exciting space is understanding the underlying whys of why some medications work for some people and they don't for others. And having precision care is a really exciting space.
Hear, hear.
Here, here.
So I will jump in on tag along on what's on the horizon and what I would love to see. And that is a focus on the inflammatory aspect of endometriosis, and that we know the peritoneal fluid has markers of inflammation, cytokines, free radicals, that this disease state is maybe a syndrome, right? It has along with it gut issues, inflammatory issues. Patients sometimes report that after excision, their joints feel better. So we know that inflammation, systemic inflammation, is relevant here. And so I would love to see more medications that focus on that. Right now, what we have are more alternative things. We have N-acetylcysteine. We have other supplements that maybe help, and in the literature seem to have some promise. But is there a pharmaceutical role for addressing the inflammatory aspects that go along with endometriosis and seem to make symptoms worse?
You know, I just want to stay on this call. We can just extend it because this is exactly the people I want to hang out with and talk about because, you know, at the same time as we appreciate the medical options we have, you know, if somebody doesn't want a contraceptive, if somebody doesn't want to endure pseudomenopause, as much as that's what we have, it's not acceptable. Like it isn't targeting therapy. And so for me, it's the non-hormonal medical therapies that will target the disease directly. And so I've been part of many clinical trials, and we did have quite successful trials in other alternative spaces, something called the selective progesterone receptor modulators, which definitely helped. Unfortunately, they haven't come to market for many different reasons. One of the big reasons is up until recently, nobody really saw a financial benefit from investing in women's health. So because of this group and others, we have to advocate to do more research. And, you know, we have to be careful because this space is going to be filled by unproven medical therapies you can get on the internet. And so anybody listening to this, if somebody's promising you they can cure it with an Amazon package, please avoid it. But there are works right now that our own team is doing. We have a large, what we call a CIHR grant, like your NIH grant, looking at precision medicine, looking at non-hormonal therapies, and immune modifiers, things we would normally treat other inflammatory conditions, like Shanti said. They haven't even come into the space for gynecology. Why not? And so we need to look at those areas. And I'm very excited to be involved in those trials. And I encourage everybody, physicians, surgeons, to be involved in clinical trials. The only way we're going to make a difference is if your voice is heard, participate, and enroll patients, and then we'll see a difference.
You know, and I think just hearing all you guys talk, I'm so excited about this work that's coming out. And I think like it's a call out to action for our patients to demand more research, right? For industry to recognize that this is a huge market that's really, really undertreated. We're talking about 20% of people with a uterus have endometriosis. This is a huge number of people, right? Like, and so like, I always say, you know, when I talk to my patients, I'm like, go out there, go advocate with, you know, people up in government to say we need more research in this regard because there are so many patients in pain because of endometriosis and we don't have the drugs to treat them that are non-hormonal. So thank you guys all for being sort of leaders in this area and really being people part of the research and getting out there and advocating for our patients. Before we wrap up, I'd love to hear if you guys have any final thoughts for our listeners about, you know, one thing that they should know about how to medically manage their endometriosis. I'm going to fire it up. Cara, you're first.
All right, two things that come to mind. One, medications can have a role, but if you're seeing a provider who's putting you on medications continually and they're not working, and you've been on them for at least 3 months and you've had no relief, the time is potentially to shift the route and see somebody who can offer you more options. So again, we are surgeons and that is high on our priority list of making sure that we are treating you appropriately. So if medications are not working, make sure you're seeing somebody who can give you alternate options. And the other main pearl is that medications aren't trying to put a Band-Aid or suppress symptoms. They're part of a grand strategy on how to suppress the disease process. And the first and most important priority here is you, the patient. And so individualized care is number one, and that the right management is the right option for you at that time in your life and where you are in your journey and your priorities. So again, meeting you where you are.
Love that. Shanti, anything to add?
Yeah, one thing I want to echo back to something that Sony said earlier, which is that a lot of the hormonal medications that we have available are temporizing, but they don't actually, I forget the word you used, it was beautiful, but they don't modify the disease. They don't reduce the disease, except, of course, in the state of ovarian cysts and endometriomas. So to remember that they are temporizing and that they may be very useful for a period of defined duration, and that if once that duration is over and you need to then decide if you're going to have surgery or try something different, that medical management is not the end all fix all, that it's a temporizing thing to help get through the pain and management. And to not be afraid to try something new, to try something for a short period of time and see how you do. Most of these medications, with the exception of the injectable long-acting ones, are reversible, as Cara pointed out. And finally, also, that in my practice, and I think everyone here, I'm preaching to the choir, but we all, I think, have come to see that there should be a multimodal approach, that surgery is one of those approaches, and we're all kind of gung-ho in terms of that, but that physical therapy, that lifestyle management, that dealing with your microbiome and your body levels of inflammation and immune function may need to be addressed, and that medical management may also play a role. So I just want to say that I really believe in the whole person, the whole picture, in terms of using these multi-modalities in feeling better. That's our goal, right? We want you to feel better.
Absolutely. Sony, take us home.
So pain is complex, and I think that's one of the things that I try to share with our patients, to learn more about pain. Understanding pain improves your whole experience in terms of how you're going to navigate this very complex topic. And endometriosis can cause pain, but treating endometriosis surgically may not solve all the pain issues as well. And sometimes, and this is the population I worry about the most, when you don't have endometriosis or you don't have a diagnosis, but you're suffering in pain, you matter. And it is a real issue that we need to help with. And medical management and all the stuff Shanti talked about all come into play. So don't forget that we're there on your side. Let's chat. Let's go through all your options. And we're there to work with you. We're partners. And it might be medical management during one part of your life. It may be surgical management. It may be surgery and then back to medical management. But we're in this together. And I think this group especially, I think just shows how much we care. And we represent thousands of other gynecologists out there who are really interested in working with you.
I love those final pearls for our patients. And yes, for all the patients listening, I'm going to repeat what Sony said, which is really like, we validate your pain. We hear you, we see you, we know you have it. It doesn't matter if you've been to 10 doctors before us. We see you as the people having pain. Even if we can't find it on imaging or even find it at the time of surgery, we know you're in pain and we're here to help you get through that. And so that is kind of one of the goals of talking about the medical and the surgical and the procedure, all the different things we do for endometriosis. But I really, really can't thank this panel enough for the amazing care they take of patients all over the country, all over the world. And really, I'm so glad you guys are here, really trying to bring truth to some of these difficult topics, because we know there's so much out there on the internet. So thank you so much for joining me today. And thank you to all of our listeners for tuning in.
Thank you for listening today. We hope you enjoyed this podcast. To listen to other podcast sessions, visit us at gynawareness.com. You can also follow or subscribe to the Gynawareness podcast on Spotify or Apple Music.